everyone, and welcome to the Merit Education Rounds. I am Dr. Ella Piljic, and I'm an education scientist in the Department of Pediatrics and the McMaster Health Education Research, Innovation, and Theory, again, or the Merit Center. And so the Merit Center is an education services center in the Faculty of Health Sciences, dedicated to advance health professions education scholarship with a vision to grow a community of scientists and clinicians to advance health professions education through research and applied science. And although today's education rounds is virtual, many of us in this event are connected by the land on which we work. So I take this time to recognize that McMaster University is on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the Dish with One Spoon Wampum Belt. That wampum uses the symbolism of a dish to represent the territory, and one spoon to represent that the people are to share the resources of the land and only take what they need. Now, before leaving the stage to our esteemed guest today, I will provide a brief introduction. The title of today's education round is Seamless Transitions or Slippery Slopes, Exploring Learner Education Handover. And we have Dr. Susan Humphrey-Murto as our speaker. Dr. Humphrey-Murto is professor of medicine at the University of Ottawa and maintains an active clinical practice in general rheumatology and osteoporosis. She is the associate director of the Education Scholarship for the Center for Innovation in Medical Education, Competence Committee Chair of Rheumatology, and holds a Tier 2 research chair for medical education research. And her research interests include performance-based assessment, rater bias, learner education handover, and the use of consensus group methods. And with her expertise in mind, the rounds today will focus on considering the multiple purposes of learner handover, current guiding principles, and apply these to our own context to design approaches that are fair and foster a growth mindset. During the rounds, feel free to use the chat for comments and questions, as I will ask those during the Q&A period. Also, during the Q&A, you can ask questions by using the hand-raising function. So without further ado, please go ahead, Dr. Humphrey-Murto.
Thanks for the introduction. A few things have changed, actually. I'm no longer with SciMed because I was seconded to be division head in rheumatology. But I still have my research chair. So welcome, everyone. Thanks for joining. And there's Jonathan on the move. He's not in the car yet by the looks of it. It's a beautiful sunny afternoon, so the fact that you're online warms my heart. I have no conflicts of interest for this talk. I do get honoraria for speaking about osteoporosis medications, but I promise you I won't speak about any of those today. I had some objectives that I jotted down here for you. Hopefully by the end of this session, you'll be able to describe how prior information may impact assessment decisions. You'll have a clear definition of learner handover, list perceived benefits and risks, and maybe consider implications in your own context. So the polling questions are not really polling questions. They're just going to be provided for you to reflect a little bit about your current practices. And then we'll go over some of the reviews that I've been involved with. We'll talk to you a little bit about experimental and qualitative studies. We'll think a little bit about the UGME to PGME transition, and then hopefully we'll have some time for questions and discussion. So let's start with a definition. So I will intermittently use learner handover, learner education handover. I don't tend to use the word forward feeding, but they're really the same thing. It's basically the sharing of information about learners across educational phases and between faculty supervisors involved in their education. So that's sort of a definition that covers all of it. And with that in mind, I have some questions for you to think about. And I'm just going to keep moving you guys around because you're in my way. So first question is, do you and or your institution currently provide education handover about learners between rotations? So in other words, if you're doing a respirology rotation in your med student and then you go to your rheumatology rotation, is there any sharing of information about you as a learner? So my question is that a yes, you do that, or no, you don't do it, or sometimes, or you have no clue, because some people don't know. The next question, which we are not advancing, interesting. Okay. Let me move you over again. It's been going fine until now.
Feel free to maybe like, oh.
Did it go?
No, I don't. Oh, no, yes.
So the second question is, if do you provide education between learner handover between undergraduate and postgraduate education? So when they go from UGME to PGME, do you share information about the learner with their residency program? Yes, no, sometimes, or I'm not sure. If you selected sometimes that you have learner education handover, either at any level, who do you do it for? Is it the learner that's struggling, so not meeting expectations? Do you do it for the learner who's excelling, who's off the charts, doing really well? Do you do it if they're really struggling or really excelling? Or you do it for all your learners or some other combination of the above? And if you think about learner handover, does anything about it make you nervous? So maybe you're not nervous at all, or maybe you're worried about bias. Maybe you're worried it's too much work. Maybe you feel the learner isn't going to buy into this or the institution won't, or maybe you're worried about litigation. Not so much in Canada, but it happens. So I have to chuckle a little when Renata says I've been doing this a long time. This is why I started looking at this a very long time ago. So I was rotation coordinator in rheumatology. We get 10 new trainees a month, and I have to evaluate them at the end of the month. So resident A came to rheumatology, spent 1 month with us. And I actually worked with this resident on the first day. And they were a little bit slow to see patients and make decisions, required a fair amount of prompting. But really, it literally was day one of the rotation. So you give them a little feedback, but you're thinking they're just adjusting to this situation. And of course, the resident works with different people. By about week 2.5, a faculty member approaches me because I'm the rotation coordinator and says to me, basically describes the same issue that I had observed on day one. So I tell my administrative assistant, well, that's great, let's book a meeting. By the time the resident's schedule and my schedules align, we're at week 4. Meet with the resident, who actually was a bit insightful. And when I mentioned the problem, said, oh yeah, I've been told that before and would love to work on it. Well, by then the resident's off to their next rotation and the cycle repeats. So I became quite frustrated in the moment, thinking, why didn't somebody tell me? I wasted 4 weeks figuring out what a problem is when it's already known. So I'm not, the first person to see a problem. Back in 1987, certainly the AAMC said, we have concerns about the lack of information shared about students between rotations and lack of early warning systems when students are having trouble. So not a new conversation. So there's lots of people that think learner handover is a good thing. So because you can tailor the educational experience as the trainee moves towards competence, really fits well with the growth mindset of CBME, which we've all gotten used to. And you can avoid wasting time rediscovering learning needs, as I did with the situation that I just shared with you, and obviously build upon previous assessment and feedback. So we have supporters, but we also have a lot of people that are worried, and you can see the references down below. There have been national surveys of clerkship directors in the States, in internal medicine, family medicine. Dr. Kassam looked at key stakeholders in Canada, and people are worried about stigmatization and bias. So you label the resident or the student as having weak whatever, and then that's going to follow them. So faculty and learners have expressed concern about these practices. I'm assuming you're all quite familiar with how the world runs in medical education, but right now in medical school, you go from one rotation to the next. They can be anywhere from a few weeks to a few months, and then you move to the next rotation. And really, there's no information sharing about the student on the most part, and maybe your situation's different at Mac, about how they're doing, their weaknesses, their strengths. And likewise, generally when they go from medical school to residency, there's certainly no information sharing as they go into residency, what they need to work on. So faced with this problem, we asked ourselves, certainly I went to the literature saying, okay, everyone's so worried about bias, like what's the evidence and what can happen? So if you look at the psychology literature, 3 things can happen when you're given prior information about someone that you're about to assess. So there may be no effect. So I may be told that resident X is struggling with communication. It may have no effect. It may have an assimilation effect, which means that the target rating that I give is biased in the direction of the past performance information I was given. Or it might cause a contrast effect, the opposite, where my target rating might be biased in the opposite direction from the past performance information. So just to make this super clear, let's say I have a rater and my rater watches an average performance. They should provide an average rating. Now, let's say we give prior information to that rater before they see the performance, like perhaps written information about somebody. And let's say we tell them that person they're about to see is super. They might give a higher rating than they otherwise would have. Likewise, if the information that we give is negative and they watch the same average performance, they may provide a lower rating. And that is what we call the assimilation effect. So when we started looking at the literature in medical education, we really didn't find anything, i.e., was there assimilation in medical education? But we did a scoping review that showed that in the non-medical education literature, it was there. One example on the far left, you can see the picture of the lecturer. Some of you have done psychology degrees. I didn't realize how many studies you're part of. So you take about, 100 psychology students and tell them the professor they're about to see a video of was one of the best teachers ever. You take another 100 psychology students and tell them he's the worst teacher ever, and you show them the same video. And as you might expect, those that were told he's amazing rated him higher than those were told he wasn't doing so well. Likewise, if you put curtains in front of people doing performances, like playing the violin, you're biased. And they did some really interesting studies with skating judges where they literally took old skating videos, changed the names. So they had Ontario judges and Quebec judges, and they made all the Ontario candidates have Francophone names, and the English ones are the opposite, and they were biased as well. So across multiple contexts, we see this effect. The other thing we noticed as we were reading the literature is there are things that may impact how much of that assimilation occurs. So for example, if you give negative information, prior performance information, it tends to have a greater effect size than if you give positive information. The other thing they noticed with studies, not in the medical education context, but cognitive loads. So in one instance, they gave information before you had to rate a performance, but during the time you were rating a performance, you also had to do some other task, like what are the 10 uses of a 2x4? And in those instances, if you were cognitively overloaded, you were more likely to see assimilation. Some raters may not be affected by prior performance information. In one study, they showed about 20% of the raters weren't affected. And in other studies, they tried to look at as it part of your personality. So in other words, if you're an entity theorist and you believe that people are born this way and can't really change, you may be more prone to be affected by prior performance information than if you're an incremental theorist and you think people can change and learn. Sadly, most of the studies that we read showed that rater expertise and rater training really did not help the situation. The other thing that might affect it is down on the bottom there is making raters accountable. In one study, $25 did it. So in experimental settings, if people were given an incentive of money, they did better. And in other situations where you said they would review a performance and rate it, but that they would have to then describe why they made that judgment, it also reduced the assimilation effect. There's very few studies on combining factors. One in particular looked at past performance information being negative or positive, and also looking at the person's BMI, normal versus high BMI. And they showed that in those instances, there was an interactive effect. In other words, negative prior performance information and an elevated BMI had more negative scores. And the other thing that was fairly consistent is if you have an average performance, you're more likely to be biased than if you have a very good or bad performance. So, and these were not consistent across all studies, but these were trends that we saw in the literature, in the non-medical education literature. So about the time we were there, Tammy Shaw was doing a master's in education and decided she wanted to take a deeper dive on this. So we basically did an experimental study where we had faculty raters and we gave them either positive or negative learner handover and showed them the same video. So how did that look? We had 42 raters, divided them randomly into 3 groups, and they received either positive learner handover, which I'll show you in a moment what that was, nothing, so the control group, and negative. We showed them 6 videos of residents seeing patients, and these were authentic in the sense that we actually video recorded patients in my clinic seeing patients, and we had those interactions transcripted, and then we had them portrayed by actors. So we would not have any patient confidentiality issues. And then we had our faculty complete a mini CEX. We lied to our raters what the true purpose of the study was. We told them we were looking at basically the psychometrics of the mini CEX. And Tim Wood was on the team, so made sure we had a good design, where you can see Group A raters in some videos received negative learner handover and others positive learner handover. And Group B was the opposite, and Group C did not receive learner handover at all. So just to give you an idea, the cases were varied. We had male and female actors portraying different cases in different contexts. The learner handover tool, you might be interested. So we said the program director is now forwarding educational information of the resident based on OSCEs and ITERs. And here's some information for you to consider as you're about to see the video. And we made it pretty biased. So if you were positive, you were really positive in all aspects. So you were an expert, you were really good at medical expert, you were a really strong communicator, and you had no issues in professionalism. And if you were struggling, we made you struggle across the board. So you were weak at medical expert. You can see the words. We didn't mince our words. You were having difficulty. Even in our world, average is a bit of a signal. Well, we didn't make it, we made it obvious. So they were having trouble across all of the domains. The mini CX, in case you're wondering, so we use the standard mini CX that's in the literature. So what did we find? If our faculty members, and I can tell you these were all experienced faculty members, they've been basically observing residents, having them in their clinics for years. If we gave them negative learner handover, their mean score for the mini CX was 5.29. If they had positive learner handover, the score was 5.97. It was highly statistical significant with quite a significant effect size of 0.81. If you compared negative to no learner handover, and if you compared positive to no learner handover, there was no difference. We wondered if they guessed what we were doing, and 80% guessed. We asked them point blank at the end in a survey, what do you think we were doing? And 80% said, I think you're seeing if I'm biased. So the conclusion from that study was that we had an assimilation effect in an experimental medical education context, where the faculty provided with negative learner handover generated lower scores than faculty provided with positive learner handover after viewing the same performance. And that was despite having experienced rater and raters who actually kind of figured it out. They knew what we were doing. The differences were small, but we thought this might impact a borderline candidate. Now, our team then said, okay, but you don't always work with someone. Like even within a clinic, they may have multiple performances, right? They're going to see multiple student or multiple patients, and I might work with them several times over a week or month. So what happens then? So again, we went to the literature to see what we might find. And this was an interesting study done in the psychology literature. And it was quite contrived in that undergraduate students had to pretend they were department supervisors. But the bottom line was they had to rate written information about a hypothetical employee, and they were given performance information beforehand about that employee. But it was incongruent. So in other words, if they said, their previous job, they really were struggling and not great, you then showed them 9 amazing performances. And opposite, they said if they were doing really well in their old job, you then showed them 9 crappy performances. And what happened was after the first performance, you had assimilation. So in other words, their ratings moved in the direction of the information they had been provided. But by about the 3rd or 4th performance, their ratings became more consistent with the performance itself. So the assimilation effect was gone. So we replicated this with real faculty. So our purpose of that study was, does learner handover influence faculty ratings? We wanted to look at entrustment decisions because entrustment decisions affect how much a staff member, faculty will let people do. And we also wanted to look at feedback. So after observing several performances of the same learner, and we expected to see bias after the first encounter based on our previous study, but we hoped that over time we would see less bias. So this was how the study was set up. We had the same resident do every encounter, a white male. We basically took many videos and many takes to get average performances across all these problems, heart failure, urosepsis management, and so forth. And the learner handover conditions, again, some faculty got positive, some got negative, some got nothing. And after each video, the raters completed an entrustment scale of mini CX and gave feedback, written feedback. Give you an idea, this was a challenging study for recruitment. I'm not going to lie. We had 57 raters across several universities. They were all internal medicine specialists, male, female, fairly evenly divided. But what I want to draw your attention to again is, you know, how many years have they been supervising trainees? I'm hoping you can see my cursor, but, you know, over 10 years, 20%, 18, these are numbers, sorry, not percentages, 18. So these are experienced faculty who've been doing this quite some time. And what did this study show? Well, nothing. Essentially, you can see here, these were for the videos across the x-axis. So for video 1, whether you were in the negative learner handover condition, which is the red line, the control condition where you got nothing, or the positive condition, you can see that the entrustment scores, and I'm not showing you for the rest, but the mini CX scores, it was all pretty much the same. What we had was variability in performances on the videos. So you can see 1 versus 2 was different, but you can see the lines are following each other for the most part with a few minor differences. But for the most part, we did not see any assimilation effect, whether we looked at entrustment ratings, mini CX scores, or feedback valence. We found that there was really no effective learner education handover as we expected, or unlike we expected, because we expected to see it after the first go. In the exit questionnaire, we did ask them, did they feel that the information they received was credible? And most of them thought it was credible. The people that thought it wasn't credible said it wasn't credible because it wasn't consistent with what I saw. So if they disagreed with what the learner handover was, they said they ignored it. These guys were a lot smarter, actually, less smart than the other ones, in that only 30% guessed the true purpose of the study. So we said, what do you think we're doing? And they had all kinds of theories about, you know, looking at entrustment scales and comparing them to MACX. So they didn't guess it. So our conclusion at the end of this one was, contrary to previous studies, we didn't find an effective learner handover on one or several encounters, looking at entrustment ratings, mini CX scores, or feedback global valence. So now we're in a situation where literally, if I summarize for you the literature, we have 4 experimental studies that have looked at this, looking at whether learner handover bias will bias ratings. And the first 2 on the left, I've just shared with you. But just to walk you through is maybe why are these, you know, different? Well, they're all randomized controlled trials, and they all had videos involved. In our situation, we had positive, negative, or controls, positive, negative, or controls. In Valerie Dory's study from McGill, she made them weak, but either in medical expertise or communication. So she said she didn't make them weak across the board. So she made it a lot more nuanced. So it was a minor weakness in one domain. She had fewer videos, but you can see that she found no effective learner handover. And initially we thought maybe that was the key ingredient, was that it was kind of a little bit vaguer, right? It wasn't weak across the board. But as I just showed you for ours, we made it quite dramatic across the board, and we showed assimilation in one study and not in the other. How about this other study that's recently been published? This one, the learner handover information was almost nothing. 2 words. You either got above average or below average. That's all you were told. And then you watch the same video. And in this case, they showed an assimilation effect. In our study, which I didn't show you, we showed that the negative effect size was higher than for the positive. So if they had negative learner handover, the effect size was higher, as we've seen in non-med ed literature. In the other studies, the other thing they looked at was whether gender influenced things, and it didn't. And Valerie Dory's study, it was kind of interesting. They had a questionnaire to look at the mindset, whether they were more growth mindset or not, and that didn't seem to make a difference. So where do we go with all this now? Well, we got 4 studies, 2 of them showing no effect of learner handover biasing and 2 that do. So, we do feel that at this point, I think all we can say is information sharing may or may not bias future assessment. And I think producing such effect is elusive. In some of the non-med ed literature, they asked managers how many things they factor in that they can think of when they're rating someone, and there's like 6 or more things. So I think trying to predict this is, to be my take, is impossible. We do know that CBME, at least we think it demands educational continuity. So the next couple of studies we did were basically, what do people think's going on, in the real world? What's actually happening? What are people thinking? And so I was lucky enough to work with Lorelei Lingard, took a sabbatical a number of years ago, and had some great collaborators, as you see. Corey LaDonna and Lara Varpio were also helping me out. And basically, we wanted to look at how faculty members perceived and enacted learner handover. And so we did a constructivist grounded theory study using 23 semi-structured interviews with faculty from the University of Ottawa in Western Ontario. And what we discovered was we did give them the definition of learner handover, but they described quite a spectrum. A very formal learner handover, like you might see if someone was a struggling learner and the preceptor was given information before they arrived at their clinics or in their rotations. They could be structural exchanges. So a lot of faculty, when they were handing over patient lists, would hand over resident lists, like resident A is doing really well, but needs work with this, for example, to the very informal hallway conversation, like, hey, so-and-so is coming to my, rotation. How are they? So more informal. They also described to us that it was complex with multiple goals. So some of them they felt like were officially approved, like if you're helping a struggling learner, and also important from a patient safety perspective. So if someone was deemed unsafe, that was okay to be sharing that information, and maybe used to improve faculty efficiency. But things that came up that maybe were a little unsanctioned was faculty's insecurities managing assessment. So if they saw someone and they weren't sure that it was, a weak performance or they were overreacting, they might go to their colleagues and say, hey, you kind of seeing the same thing I am. Also, they worried about how much to entrust the learners. So on call, for example, or some of the surgeons would say they'd want to know, was that learner someone they could trust to go down and emerge on their own and evaluate a patient? And sometimes they said they just wanted to vent. So they had a horrible weekend, the resident couldn't handle this or that. And they all kind of felt, a little uncomfortable about it, saying it was kind of perhaps gossiping at times. So the bottom line for us that was learner handover was complex. It included both sanctioned and unsanctioned purposes, and that really formal educational policies need to recognize these multiple motivations that faculty may have for engaging in various forms of learner handover. This is one quote from that study where faculty were expressing concerns about bias, and what, we describe as self-fulfilling prophecy. And, that quote, every little mistake that the learner makes will be interpreted as some egregious error rather than the normal learning process. So they didn't want the resident to feel like they were under the microscope. So of course, if we asked faculty what we thought, we also wanted to ask our learners what they thought. So Tammy Shaw did another study, and we involved Karen Auer as well in this one. What were the perspectives of the learner? And so the aim of this study was to explore the learner's real world experiences of learner handover, including their underlying beliefs that may affect their acceptance of this. Again, constructivist grounded theory. We did 29 semi-structured interviews with medical students and residents from the University of California and University of Ottawa. And here's a quote that defines a lot of what we heard from the residents. Quote, I feel like there's always a pressure to perform, not just because you want to do well, but also knowing that like making mistakes, they can follow you and affect future avenues. Medicine is a small community, so mistakes follow you. So this idea again that one little error could stick to you and either affect your ability to get into a residency program, or if you're a resident, affect your ability to get a job in an academic center. So our conclusions from that study were learners are uncertain whether learner handover even occurs. It was quite interesting when we talked about it. You could see them reflecting on whether it had ever been done or what they knew about it. They were aware of the potential benefits, and they really did. They said, we understand the faculty need to know if we're competent for patient safety, but they were quite worried about the potential consequences. And one of the things we heard was this unintended consequence. We think of this heightened pressure to perform all the time, always being on, because one little performance could sink them. And so I think we need to consider that if we're going to engage in learner handover. So thrown a lot of concepts at you. Let me just wind it up to how this might play in real world. So let's say you're sitting on a competence committee for your specialty. You hear there's a second-year resident who's really struggling with communication skills, and the next week the resident shows up to your clinic. Is this going to bias you? So based on what I've shared with you, it may have no effect, or it may have an assimilation effect. Because it's stronger, it's negative, maybe it'll have a stronger effect. On the positive side, though, maybe you'll be able to give targeted feedback and really help that resident advance. If you're in a busy clinic, maybe that will make you, more biased. And maybe after several performances, you'll be less biased. How about another real life scenario? You're about to start a busy week in a call. Your colleague does patient handover, then shares information about learners on the team. And let's say you're given accurate information that resident JM could work on their differential diagnosis. What might happen then? Or maybe you receive inaccurate information, stronger week. What might happen? Well, if you're given accurate information, maybe you'll give targeted feedback that'll actually allow the resident to improve. If you're told they're strong and maybe it wasn't quite accurate, you might limit your supervision. And that means less feedback and maybe some patient safety concerns. And if you're told they're weak and they're really not that weak, then maybe you're going to deny them learning opportunities. And we heard this from our surgeons, where if people came with a label of being weak, they wouldn't let them do as much in the OR. So these are just examples of how this might play out. All right. So how about moving from medical school to residency? What happens in this particular scenario? I'm sharing some slides from Helen Morgan. She is in the US and has done a lot of this work. So Helen Morgan is in the US, but this is very similar in Canada, where we have our residents or I should say our medical students in our fourth year doing a lot of electives, almost like, they're trying to get into their residency of choice. And then they have this big competitive process where they are selected to go into a residency position, this application process. And then from the time that they put in their application until they finally, finish medical school in May, none of that performance information is really shared with PGME. And it's not shared perhaps even before then, and we could debate that one. So Helen Morgan has come up with what she calls a responsible educational handover. So how you can improve communication to improve learning. In this came out of 32 medical schools trying to talk about how they might share information to improve resident experience. So they had sort of 5 overarching themes that they came up with. One was that the purpose of the educational handover had to be clear, and it was to really provide medical school performance data to guide continued improvement in learner ability and performance. And the goal had to be not selection, but preparation. So it absolutely had to happen after they were matched, not before. And it might allow the program directors to be better prepared for residents entering their programs. Maybe adjust their schedules, for example. It needs to be a cyclical process with this in mind. So it should create an educational handover that's philosophically and practically aligned with learners' continuous quality improvement. And obviously it's part of the cycle, right? collect data, give them feedback, let the learners reflect on their own performance was a key feature of this, where they needed to be part of this process. The third thing was the learner ownership. So it had to be driven by the learner with a focus on individual learning plans that would be co-produced by the learner and the coach. And these learning plans should be included in the learner handover to guide their transition. So they should actually come with their individualized learning plans when they enter residency. There should be some form of standardization of format and content, aligning with the needs of both the students and the programs receiving them. And then finally, and where we often fail, is we need infrastructure to do this. So medical schools and residency programs need to invest in adequate infrastructure. You need coaches, you need advisors, you need systems to provide adequate performance data and opportunities, if you're going to do this in students, to improve before residency and throughout residency, of course. Canada came up with similar guidelines. They said if you're going to do this, it needs to be after the match. It really needs to be centered on what the learner needs and forward-facing, so not punitive. And that you should do it not just for struggling learners or exceptional learners, but for all learners in all schools. So standardization across the board. So people have tried to institute these things, and how's it going? So when does it get to the real world? Well, I can tell you in the US, again, this is Helen Morgan, they have done this. So in surgery, OBGYN, and pediatrics, they basically created milestones, handovers, which were given to residency program directors. And without getting into the weeds, these were formal letters accompanied by the milestones and how they were doing on each milestone and what they needed to work on. And Helen did this for a number of years and continues to do it, but she shared some lessons from her 6-year experience on this. One is it was extremely time intensive. Much of Helen's job in postgraduate education was basically she was allowed to do this as part of her day job, but she found it time intensive. She became a little bit frustrated because she was the one institution sending the information to the postgraduate programs, but she was never receiving it. So limited when only one institution's providing the learner handovers. She did some studies again showing the learners were nervous about this. One study in particular, learners who had never experienced this were very nervous about it. Learners who had experienced it were almost not very nervous about it because they understood the process. And of course, some faculty were quite skeptical. And at this point, so surgery and peds stopped doing it in her institution at University of Michigan, and only OBGYN continued to provide the learner handover. But again, she was finding it more and more difficult. In Canada, they tried to institute this a number of years ago. So Leslie Nichol was leading this. And basically, I quote here from her, when the day came to request the Canadian undergraduate deans to approve the implementation of learner handover protocol, it was denied. They were concerned about the time and they just didn't have capacity to do this. So perhaps people agree in principle, but it is very difficult to implement. So where does this leave us? And I think a lot of it is, I think we're back to this. I think it's back to basics, assessment for learning versus assessment of learning, and this tension between the two. It was very well written by Chris Watling and Schiffer Ginberg's the risky recipe, right? So learner handover on the one hand for learning really does fit very well with CBME and a growth mindset. But on the other hand, we've got people who are reluctant because they're worried about, is this used for admission? Is it used for pass-fail decisions? So maybe instead of kind of an all or none, maybe we just need to implement, maximize what we're doing. And at the end of the day, it's going to require a change in culture. And we know how easy that is. So I'm done with the slides and I'll take questions. We've reviewed, got you thinking with some polling questions. So hopefully some of you will have some thoughts. Gave you some information on some reviews and experimental studies, and talked a little bit about the challenges of UGME to PGME. And I'm happy to take any questions.
Perfect. Thank you so much. And thank you again, Dr. Humphrey-Murto, for being our speaker. I think it really created a nice conversation and discussion. So thank you everyone for attending, and I wish you all a great evening. Thank you.
Thanks, everyone. Nice to see
Thank you.
your faces. Bye now.